He has to unmute.
Yeah, but with yes. Okay, so it gives me immense pleasure to introduce our to welcome our president, Dr. K. Mishra sir. And sir, can you hear us? Are you there? Mishra sir? Sir, we would like to have a few words from you. Maybe if it's not possible right now, we can have that later on. Host, can we have the speaker slide, introduction CV slide? Or Smith, can you share that?
Yes, ma'am, I'm just sharing.
Yeah. Yeah, so soon we'll be having his slide on the screen. Meanwhile, I can start introducing him. Dr. Harkishan Mamtani has done his MD Psychiatric from NIMHANS. He has done his PDF Neuropsychiatry and MRC Psych from UK. He has authored more than 30 plus publications, out of which 21 are in PubMed indexed journals. And he has written. Okay, Mishra sir has just messaged that since he's traveling in the train, there is lot of disturbance. So maybe when he gets the signal, we can have his words. I'll continue. Dr. Harkishan has written 3 book chapters as well. He has got a Young Investigator Award by World Federation of Societies of Biological Psychiatry in Istanbul 24. He has been endowed with Overseas Bursary Award by Neuropsychiatry Faculty, Royal College of Psychiatrists in London 24. And he has got other quiz and research awards at various national and international conferences. His areas of academic interests are consultation liaison psychiatry, neuropsychiatry, integrative medicine, women's mental health. That's interesting. I've seen very few men taking interest in women's mental health and suicidology. And currently, he is a consultant psychiatrist and director at Manoved Center for Mental Wellbeing and Research, Nagpur. And he is the host of Mental Wealth with Dr. Harkishan Mamtani podcast. So, Dr. Harkishan, I invite my warm welcome to you, and we are hoping to learn a lot from you. Over to you, Dr. Harkishan.
Thank you so much. Thank you so much for the kind introduction, Kathy ma'am. I hope I'm audible.
Yes, very clearly.
Right, yeah. At the outset, thank you to the Child Psychiatry Subcommittee and IPS West Zone, Neha ma'am, and everyone for having me here. We'll be discussing about co-occurring OCD and autism. I mean, we might be seeing OCD and autism like separate entities in our OPDs, but this is another common comorbidity which needs to get the much deserved attention. So I'm glad that the organizers agreed for this topic. When I was going through the literature trying to find some recent papers, I came across this very interesting qualitative study, and this somehow caught my attention. Published last year, the title says, I mean, it quotes one of the patients of autism with OCD who said that autism is the arena and OCD is the lion for him. So essentially he described as the arena where he's living. He's already struggling with autism, and OCD is something which is over and above that, bothering him or her, and that's how he's finding that very dangerous and overwhelming, and he calls it the lion. So, on this note, let's start to talk about these two entities in isolation first, and then we'll move on to the comorbid autism and OCD. OCD, as we all know, is repetitive, intrusive thoughts, images, or urges, which we call obsessions, with quote unquote purposeful mental or physical actions which are aimed at reducing anxiety caused by these obsessions. And autism spectrum disorder, like we all know, are impairments in social relationships and social emotional reciprocity and non-verbal communication combined with RRBIAs, which we refer to as restricted and repetitive behaviors, interests, and actions. This is according to DSM-5. Now, interestingly, until the DSM-4 TR was published in 2000, the year 2000, you could not make a comorbid diagnosis of OCD and autism spectrum disorder. This was like an exclusion criteria for either of them. So our seniors who are here, they'll tell us like before the year 2000, you could not make a comorbid diagnosis of these two conditions. But over the years, it has been realized that these two entities have certain differences, even though the repetitive behaviors is a commonality, but they are still not on the same spectrum. So that's what gave this birth to having this separate clinical entities of OCD and autism, and they can also be comorbid. Now, quickly, we'll just have a look at a few numbers just to know the magnitude. OCD in child and adolescent population, according to global studies, the prevalence is up to 4%. India, there have been smaller studies where they found the prevalence to be somewhere in the range of 0.1% to 0.8%. So essentially less than 1%. This is all population based studies carried out in schools and adolescents. Now, coming to the prevalence of autism, WHO says that autism is found in 1 in 160 individuals globally, whereas coming to the Indian prevalence, you can say that it's roughly around 0.1% in age group 0 to 18. Rural, it is very slightly more than the urban population. So looking at this prevalence data, now let's see how common is OCD in autism. So essentially, if we keep the diagnosis of OCD aside, if we just talk about the prevalence of OC symptoms in autism spectrum disorder, the prevalence can be as high as up to 37%. And it has also been shown that individuals with autism spectrum disorder are 2 times more likely to have OCD than general population. Now, if you look at the pooled prevalence of co-occurring OCD in autism, it can be anywhere between 9 to 12%. And a very recent paper has shown that this co-occurrence is more common in males. And it also interestingly showed that intellectual disability is somewhat more common, but this is something which has not been replicated across studies. So, bottom line that it means, I mean, just trying to convey that autism is much more common in OCD than as compared to general population. Now, let's go the other way around. Co-occurrence of autism in OCD. Now, if we look at this, there is a high likelihood of undiagnosed autism spectrum disorder in OCD patients. One of the studies done in 2018 showed this rate to be almost up to 50%, so which is a very significant number. Goes to show how challenging it is to diagnose these two co-occurring conditions. And interestingly, another study showed that when someone with OCD is 4 times more likely to have a diagnosis of of autism spectrum disorder than general population. So again, the reverse is also true. Just going to show that how common this comorbidity is. It has also been shown that in pediatric patients with OCD, the subsyndromal symptoms of autism spectrum disorder are also very frequent with the range. I mean, it's almost up to 1/3 of those individuals having these subsyndromal symptoms of autism. And in an Indian study in 2021, in OCD, it was found that up to 6% of individuals had autism spectrum disorder. So it has also been shown that tics, symptoms of ADHD, and pathological doubt correlated with increased symptoms of autism spectrum disorder within the OCD population. So essentially, these two slides might be a little too heavy to grasp, but like I said, the bottom line is that these two conditions are way too more commonly comorbid than what we can think of. Now, what can be the reason behind this? I think this is something which has been very recently identified, that there is some sort of a shared genetic vulnerabilities in these two comorbid conditions. Some genes have been identified, which are there on the screen for you to see. And this is something which has also shown up in some of these interesting findings um in some of the studies done on the role of family history. So let's say in mothers of children who had autism, there has been a higher prevalence of OC symptoms. And when you compare this with mothers of children with OCD, they also have higher prevalence of symptoms of autism spectrum disorder. So essentially, mothers of the other disorder are more commonly found to have the other comorbid disorder. So this is again something which points to the common link between autism spectrum disorder and OCD. And another study which also showed that autism spectrum disorder, I mean, people with only autism spectrum disorder had higher scores on restricted repetitive behaviors and ritual domains of the autism scale, and they also had parents with higher scores on Y-box checklist. So essentially, this slide just goes to show that this comorbidity also transcends generations. It's not just in one, but even the parents are also affected with some symptoms. So the symptoms tend to overlap, and they in some ways run in families. Now, coming to why we are here, why we are discussing this comorbidity, the thing is that it is really challenging to diagnose OCD in autism spectrum disorder. The most important limitation is something that we've already discussed in the first slide. As late as the year 2000, which is only almost 2 decades back, uh, you were not allowed to make a comorbid diagnosis of OCD and autism. So the research as a result is fairly limited, and there has been limited research. Also, one of the biggest challenges in diagnosing as a clinician is the language impairment that you see in patients with autism. A person with OCD might be very vocal about his obsessions and the ego dystonicity that comes with it. But someone with autism, you can only imagine how they'll be able to put into words complex emotions and these complex thoughts that can happen in OCD. So that's another common reason why that happens. And as we'll see ahead, that in autism spectrum disorder, the insight for OCD tends to be lesser as compared to the other patients with OCD. And also, like I've already mentioned, it's difficult to identify certain emotions which can preclude the diagnosis of autism. And Interestingly, I mean, like I already said, that a lot of times the diagnoses are also missed in up to 50% of patients because there might be some kind of a masking of symptoms. And finally, it is really difficult to distinguish the compulsive behavior in OCD from the RRBIAs that we see in autism spectrum disorder. So, this is just a small attempt to help all of us understand how these two can be different. Compulsion in OCD goes without saying. Usually, they will be preceded by obsession, so this can be a very useful differentiating point. But like I said, a lot of times it might not be there. I mean, we usually see compulsions only type of OCD, and people with autism or other neurodevelopmental disorders might find it difficult to voice their symptoms, so that differentiation does get tricky. But the key point here is that the ego syntonicity of the RRBs that are seen in autism spectrum disorder, they are in a lot of ways very calming for that person with autism spectrum disorder. Whereas in OCD, the ego dystonicity is something which we're all very well aware of. These obsessions and these compulsions are very distressing for that person. RRBs, like we know, they are sensory seeking in nature. A large number of them, not every RRB, but many of them. And another useful differentiation point, if the parents are good informants, then you can also talk about the age of onset. So the age of onset for the RRBs will be early developmental years, usually around 5 years of age, whereas compulsions, the onset is usually later, between 8 to 12 years of age. So this is essentially how you can differentiate the RRBs vis-a-vis the compulsions. The key point being the ego syntonicity of RRBs versus the ego dystonicity in the compulsions. Now, this is a very interesting study, and you'll notice through my presentation ahead as well, I quote this study very often. Martin and others in 2020 did this very interesting study on, it was a population-based study where they studied three kind of cohorts. Uh, Autism only group, OCD only group, and OCD and autism comorbid group. So, one of the parameters that they looked at was the age at diagnosis. The mean age at diagnosis of individuals who had only autism was somewhere around 10 years, 9 months, so nearly 11 years, whereas the mean age at diagnosis was around 14 years or for OCD only group. Uh, Now, coming to the diagnosis of autism and OCD in the comorbid condition, they found that it was nearly almost the same, around 13 and a half years. So it lies somewhere in the middle, like you would expect, because we already mentioned how the RRBs manifest earlier and OCD, the compulsions start to manifest a little later. So it is rather intuitive that the diagnosis would be a little late for OCD. Uh, Now, coming to another interesting slide, now it is found that there is a significantly greater prevalence of religious obsessions and lesser prevalence of checking and washing compulsions in people with comorbid autism and OCD compared to the OCD only group. So the commonest compulsions that we see in our OPDs, those of checking and washing, are fairly less common in individuals with autism. So that's another thing that makes it a little difficult to pick. And interestingly, it shows more of religious obsessions. This is something which was shown by Lewin et al. Now, another thing is that other common compulsions that we see, be it related to cleaning, checking, counting, and certain aggressive obsessions, they are also shown to be less likely in individuals with this comorbid OCD and autism. Uh, like you would expect, the individuals with comorbid autism and OCD are more likely to display the RRBs as compared to the people with only autism. So this is another thing which has been shown in research. And there are fewer pro-social behaviors and more difficulty relating with peers stemming from, of course, their autism as when it was compared with the OCD only group. So the highlight here in this slide is that the common obsessions and compulsions that we see in our clinics are rather rare in people with autism and autism and OCD. So the job of the clinician is even more difficult because then you have to dig around to really find the other lesser prevalent obsessions and compulsions. Now, coming to the functionality and severity of OCD when there is comorbid autism. Now, this is rather intuitive that you would find a lower psychosocial functioning in people with both OCD and autism when you compare it against people with only OCD or only autism. And the severity of OCD symptom was also found to be lower in this comorbid condition when they compared it with a comorbid, or rather the OCD only group. So the symptoms of OCD are rather less severe when it was compared with OCD only group. Now, this is another thing which somehow shows that there is lack of insight in people with comorbid autism spectrum disorder and OCD. People with this comorbidity, interestingly, they blame themselves significantly less for their intrusive thoughts, which is something which we very commonly see in OCD otherwise, because most of it is ego dystonic. And they believed significantly less that their thoughts can cause harm. Again, now this also reflects the lack of insight, which was again showed in another study in 2010 by Ruta and colleagues. Now, coming to understanding the comorbidities of autism spectrum disorder and OCD comorbidities. So, when someone has both of these conditions, it has been shown that they are more likely to have other anxiety disorders like social phobia or separation anxiety disorder, and also other externalizing disorders, be it ADHD or even other externalizing disorders. Now, these are things which are as compared to the OCD only group. So, when you compare someone with autism and OCD, they are more likely to have these conditions. So, both externalizing and internalizing spectrum. This brings us to us. I mean, so how do you diagnose? Now, this is the question. This is a list of a few diagnostic tools that I could come across. These are in some ways diagnose. I mean, these are in some ways tools to help you understand anxiety disorders in people with autism, because that's where the difference lies. So some scales that can be of help. There is a children's Y-box version for OCD. There is obsessive compulsive inventory revised. The kiddie schedule for psychiatric disorders in general. This also has some components of anxiety and as a result OCD. Autism comorbidity interview. That's also something that has been extensively used in research for identifying autism and OCD comorbidity. There's another children's inventory for psychiatric syndromes, the parent version that can be used, and finally the functional behavioral analysis. Now, coming to treatment, like you would expect, and like many of us would have seen in our clinical settings, someone with comorbid OCD and autism is more resistant to treatment when you compare it with someone with OCD alone. So, this can stem from the various kinds of difficulties that can come over during the treatment process, which we will see in the slides to come. But interestingly, this study by Martin et al. That I was mentioning earlier showed that people with OCD only and people with OCD plus autism, they were both equally likely to receive CBT. So the clinicians were equally prompt in recommending CBT to both these groups. But when you talk of the prescription of medications, the comorbid group had were more likely to be prescribed medications, and they also use the other services in the hospital, and for longer than the OCD only or the autism spectrum disorder only groups. And finally, it has also been shown in the same study that there were significant improvements. Now, this is something which is something that we all clinicians can take solace with, that once the services are utilized to their optimum levels, there can be significant improvements in their functioning, but the gains will be smaller than those with OCD only group. Now, that brings us to something that has been advocated as the most important cornerstone of treatment in OCD, that is the cognitive behavioral therapy or the principles of ERP that we use. Essentially, this slide, the first 4 points summarizes 5 different studies, but in a nutshell, the evidence is mixed. If I were to put it like that, there have been studies which have shown that CBT shows good efficacy whenever you give it, even for individuals with comorbid OCD and autism spectrum disorder. But when you compare it with general population, it is still, or rather, the OCD only group, the CBT is less effective. Uh, Interestingly, a couple of studies done in 2018 showed that if you also worked on social skills training along with CBT, that's something that works as a good combination therapy for individuals with autism spectrum disorder and OCD. I mean, that's something that you would expect when you are encountering these two comorbidities. The main challenges that a therapist can experience while they are doing CBT for someone with comorbid OCD and autism. The biggest challenge, I mean, we all know how integral thought diaries are for CBT, and we've been discussing right from the beginning um, how difficult it is for people with autism, for adults, for young children with autism to express their thoughts, emotions, and be these complex thoughts. They will find it difficult to somehow put it across in words or in even in writing. Then in CBT, we also talk a lot about alternate thinking strategies. So this is also something which people with autism might find a little challenging, and as a result, the cognitive restructuring thereby is less helpful. Now, these are some modifications in our usual CBT that have been suggested for OCD and autism spectrum disorder cohort. Uh, the most important step here is psychoeducation. So, if you're able to focus more on the affective identification and anxiety, because I think that is where the work should start with. A lot of times, I mean, this is something which I have also seen that the children with autism, or even adults with autism for that matter, are not able to identify what exactly is anxiety. So, I mean, the psychoeducation can begin with something as simple as identification of this affect, identification of anxiety, and subsequently the timeline that we need to follow for this cohort is something which has to be much more structured. Like we've already discussed, there's no point on, or rather, there's little success if you focus extensively on cognitive techniques. You'll have to be very receptive of the kind of acceptance that is going to come from your client who is having this comorbidity, and the cognitive techniques need to be given less importance. And very importantly, you should be helping your clients with this comorbidity to identify these triggers for dysregulation. So that is something which is going to be very, very important, and this is something which will go a long way in therapy if you're able to do that successively. It is very important to involve parents in this cohort, OCD and autism spectrum disorder, because a lot of times we've seen this that there is a lot of accommodation, there is a lot of proxy compulsions that the parents get into in this cohort, especially fearing the behavioral disturbances, fearing the aggression that people with or children with autism or adults with autism are predisposed to. So it's very important to involve the parents and educate them about what's really happening and how proxy compulsions can be problematic in the longer run, and how they can cut down on that. Then yeah, I mean, the psychoeducation continues. You have to be continuously educating them about, or rather making the child aware about this compulsive behavior. And I think personalized therapy goes a long way for individuals with autism. So, whatever the preferred interests are of the patient, if you could use those in the examples, they'll be more engaging, and the client with this comorbidity is more likely to, get in touch and rather, get in sync with what's happening. Visual aids, yes, I mean, they can play a significant role. So, if you can use more and more visual aids that will be helpful. Positive reinforcement, the behavioral therapy principles actually help. And it has also been advocated that if you can have more sessions in the home setting, that is something which will help this cohort with comorbid OCD and autism spectrum disorder. Psychopharmacology, I think the studies that I could come across are very very limited. It has not been very extensively studied. Of course, there's a lot of literature on managing OCD in isolation, but when it comes to managing OCD with comorbid autism, the literature is very limited. Citalopram in a 2009 study was found ineffective compared to placebo. Fluoxetine in another study was found to decrease repetitive behaviors, but in when it could not really translate in improvement in CGI scores or C box scores. So that's something that made it a little less promising then. In another couple of studies that were done for fluvoxamine, fluvoxamine was shown to be poorly tolerated and lack efficacy in this comorbid pediatric subgroup. But when it was tested in adults, it was found to be effective. And lastly, clomipramine has also been shown to decrease the symptoms of OCD with people with comorbid OCD and autism. The average dose was somewhere around 150 mg per day that was used in this study. So the bottom line is that we essentially have studies on these four drugs that are there on the slides, but the most promising ones is probably only fluoxetine and fluvoxamine. From personal experience, I've also seen escitalopram also work well for a limited number of patients that I have seen, but I mean there are no large studies to replicate that. Now coming to the augmentation strategies that we use otherwise very commonly. So again, not something which is super promising. Aripiprazole, two small studies had demonstrated slight efficacy over placebo, but the Cochrane review done in 2016 has negated that little efficacy that was shown in these couple of studies. Risperidone, again, it was shown like for fluvoxamine, not very effective for pediatric population, but there was some improvement reported in adults. So, I mean, it might look very bleak when you looked at these two slides, but let me tell you with personal experience, it is not as bad. It might not be as easy to treat people with this comorbid OCD and autism, but if you are, incorporating the principles of behavioral therapy that we've discussed a little earlier, I think you will see success. So essentially, this is something that I've tried to summarize. Let's say if you see someone in your clinic who you suspect can have OCD with autism, I think this patient is going to take some time. So you'll have to very carefully clarify the phenomenology, and I think over serial MSEs. I remember seeing a patient very recently in the last couple of months. It took me a couple of follow-ups to realize that that person was actually having comorbid OCD with autism, and escitalopram did wonders for that little girl later. So somehow it takes time, but if you spend time and clarify the phenomenology, the ego dystonicity, the ego syntonicity, if you're able to delineate that, that is something which will take a long which will go a long way in the treatment process. If you have the possibility, we mentioned a few diagnostic tools, so if you could use those specifically for OCD, that will be really helpful. uh, Start treatment with behavioral therapy if that is feasible. That's something which, in Indian setting, I have to admit, is not something which is super convenient. But yes, I mean, if possible, you should start that along with pharmacological management if it is warranted. And like we've already discussed, prefer fluoxetine and fluoxamine because there is some data showing efficacy. If there is poor response to these two SSRIs, you can consider clomipramine. Um, that has also shown some promise in treating OCD with comorbid autism. But yes, if you're not seeing major improvement or there is poor tolerability, then you can augment with the agents that we commonly use for OCD otherwise, that is aripiprazole and risperidone. Now, coming to prognosis, it has been shown that individuals with autistic traits, OCD children with autistic traits, they had more functional impairment, but it was not associated with the OCD severity. In a study done in 2017, uh, advancing age has been correlated with fewer compulsive behaviors in another study done in 2009. So this is something which gives us some solace. And there are some risk factors that have been, recommended as being associated with poor outcomes. So it is difficulties in interpersonal relationships, hoarding behavior, and presence of cluster A personality disorder in a study done in 2007. All these were found to have poor outcomes in these individuals. Now, I think it's important for us to recognize that science is constantly evolving. So there are certain research gaps in this comorbid OCD autism cohort that we are seeing. I think the most important lacuna that we are having is there are no Indian studies. So if I'm sure there are a lot of academicians here in our little group of 20 individuals who have joined. So if you're looking for a research topic, I think this will make an excellent research topic. Comparing, like Martin et al. That did from London, comparing OCD and autism versus OCD only versus autism only group. It'll give us a lot of useful insights about this comorbid OCD autism cohort. And it'll also help if we can identify certain specific subgroups in this group so that the therapeutic process gets a little easier. And the symptomatology that we saw certain interesting findings in this cohort. More studies on that will help us identify uh, the OCD in comorbid autism a little earlier than what we are doing now. Uh, if we can have certain CBT protocols, certain well-defined CBT protocols, that is something which will help us go a long way. And yes, RCTs need of the hour to understand the efficacy of SSRIs and antipsychotics, because the studies we mentioned didn't show a lot of promise. But yes, we need to explore this through proper, well-conducted RCTs. And finally, I think something which has not been studied but worth considering is exploring the role of non-invasive brain stimulation. Now, this is something which will be very interesting to see. So, coming to my last slide, this is just a summary of what we've been discussing in the last half an hour or so. OCD and autism are under-recognized comorbidities of each other, but they are conditions which we've seen are very commonly comorbid. Uh, it is very, very crucial to delineate compulsions in OCDs from the RRBs in autism spectrum disorder. And like I mentioned earlier, the ego syntonicity vis-a-vis the ego dystonicity is something which will help us get this delineation right. And phenomenology in OCD with autism can be different in a lot of cases. But yes, I mean, larger studies need to be done to establish this. Treatment is showing poorer outcomes when you compare OCD plus autism vis-a-vis OCD alone. CBT is a useful strategies, but if you remember that slide that I showed, certain modifications can help us in the longer run. And finally, the evidence of for psychopharmacology is mixed and limited, and certain useful options can be fluoxetine, fluoxamine, clomipramine, aripiprazole, and risperidone. On that note, thank you once again for your patient listening. I'll be very happy to take up questions if the moderator sees that we have time. Thank you.
Yes, definitely. So it was the excellent and very much clinically enriching talk by Dr. Harkishan. We invite questions from the audience, but before that, I take the liberty to start with the first question. I had a few questions in the mind while you were going through the talk, Harkishan.
Yes,
Like
ma'am.
one thing, two things. You said religious obsessions are more common in patients with OCD plus autism.
Yeah, ma'am. Yeah,
So
ma'am.
for that, I suppose the autistic patients will have to be high functioning in that case.
Right.
And another CBT with autism. CBT is more helpful in the group uh, of patients with OCD plus autism. Now, again, we know that CBT requires a good cognitive structure, that is, you can say average IQ at least, and they should be very well conversant with the language so that they can recognize and express their thoughts. So, again, this will be giving good results only in high functioning autistic patients with OCD or even low IQ
Right.
comorbid conditions.
Right. So I'll answer them one by one, ma'am. The first thing that you mentioned, I agree, ma'am. I mean, being able to be vocal about religious obsessions requires someone with autism to be on that high functioning spectrum, like we call it. Uh, but that's a finding from an isolated study, ma'am. And like I mentioned towards the end, this is something which needs to, be replicated in larger studies. So we will not be able to draw that conclusion until we have certain larger studies. Secondly, I think I did mention that the evidence is mixed with respect to the efficacy of CBT in autism, but someone with this comorbidity will have a poorer outcome with CBT vis-a-vis someone with OCD alone or OCD alone. I'll stand corrected if I said it the other way around. But I didn't mean to say that. I think the outcome is still better in people with OCD only versus OCD plus autism. And I'll go back to that slide, ma'am, if I would have said that erroneously. So yeah, this is the slide that talks about this. So it has good efficacy, but like Murray et al. Showed in 2015 that it is less effective than an OCD only group. Yeah. Ma'am, you are muted, ma'am.
Okay, CBT may be efficacious in individuals with low functioning autism or severe cognitive disability. So
Yeah.
that made me think about that.
Yeah, I mean,
Maybe,
it does not talk about comparing, ma'am. Essentially, it says that it
okay,
can be efficacious, but yes, when you compare it with autism
high
plus
functioning,
OCD
then,
versus
yeah.
only autism, then doesn't stand, ma'am. Doesn't stand that.
Okay.
Yeah.
Now there is a question or a comment by Dr. Mishra sir. Establishing ego dystonicity in ASD is a challenge and difficult to establish in low functioning autism. Your comments.
I think that's very right, ma'am. And someone with a huge experience like Mishra sirs, I rather not comment over and above that. But I totally agree with sir. In my limited experience, even I have found it really challenging. So this interesting case that I was mentioning, ma'am, uh, the child had certain repetitive behaviors, but the child was not at all vocal about this compulsions that they were having, or rather the obsessions that they were having. But then over the course of time, I tried to establish with their parents as well the kind of the chronology of the events, and somehow I was able to, I'll admit it was like a guess of sorts that it might be stemming from the OC-like behavior, even though it is just a repetitive behavior, and that's what prompted me to start an SSRI, and it did wonders. So essentially, what I'm trying to indicate is that the clinician should be open to having the possibility of exploring this possibility of having the OC phenomenology in people with in children with autism, adults with autism, when they hit a walls or when they are treating these repetitive behaviors. So that's something which should be there.
Yes, so we can say that this talk should be an eye opener for many clinicians who are seeing such behaviors in autistic patients. Like they
Right,
should
ma'am.
be watchful that this could be OCD.
Right. True, ma'am. True. Yes, ma'am.
Uh, More questions from the audience or any comments? Ritimra ma'am, Dr. Bhushan Shukla sir. Or anybody would like to make any comment or share anything?
Yeah, am I allowed, Kathy?
Yes, you are. Most welcome.
Yeah. So it was a really nice presentation, uh, OCD and autism. So I think congratulations. I just want to congratulate the speaker, Dr. Mamtani. Very
Yeah.
nice. I hope we continue on this, kind of talks, even if it is in a small group, is good. That's all I have to say. Congratulations.
Thank you, ma'am. Means a lot coming
Yeah.
from you.
Yes. Okay. Bye bye.
Yeah, bye, Ruma. Bhushan sir, your expert comments, please. I think he might not be there. Okay, so if there are no more questions, we end the session. So I invite Neha for giving vote of thanks. Neha, are you there?
So you can give the vote of thanks. Nia must have been managing the children.
Okay, Smith can do that.
That.
Smith,
Okay, ma'am.
yeah.
So I would like to obviously thank Dr. Mamtani sir for giving such a wonderful presentation. I'd like to thank the office bearers, Dr. K.K. Mishra sir, Dr. Parag Shah sir, Dr. Abhijit Faye sir, Dr. Nakul Vanjari sir, and Dr. Ina Merchant ma'am. And I also like to thank our Child Psychiatry Subcommittee, our advisors, Dr. Pangaonkar sir and Dr. Bhushan Shukla sir, Chairperson Dr. Manjari Deshpande ma'am, who couldn't join unfortunately because of her health conditions. The convener Dr. Neha Salankar ma'am, our EC coordinator Dr. Khyati Majalam. Thank you ma'am for moderating this session. The members Dr. Preeti ma'am, Dr. Swati ma'am, Dr. Shubhangi ma'am, and Dr. Jyoti ma'am. And also, I'd like to thank the audience who could join us. Thank you very much. Yeah.